Hello, good morning. So today I will be talking on the comprehensive approach, our experience in my hospital, and we call it the BIPCAT approach. So it's inverted papilloma is a benign sinonasal epithelial tumor with three different types: inverted type, oncocytic, and the exophytic. Mostly, it's the inverted type, with a history of nasal obstruction, nasal bleeding, nasal mass, usually in 50-year-old patients, and generally unilateral. These are how they appear as raspberry configuration, finger-like appearance, and sometimes if we look into the classification of Stamberger, the type 5 classification of nasal polyposis would bring us to somehow in front would be a polypoid type, but at the back would appear to be that of a inverting papilloma. So always be aware of that, and therefore the initial or surface biopsy might not suffice. So you should remove everything at the first instance. What is important about inverting papilloma is the fact that it has a high tendency to recur, relatively high in some studies. And maybe, as pointed out earlier, it can be locally invasive. And it has a tendency for malignancy in 10% of cases. And these are the experiences of some colleagues where recurrence is unacceptably high, of about 40 to 80%, and is generally due to residuals, and probably because of the approach or the way they looked at things and analyzed where the origin is. And a significant increased risk of recurrence of 51% for Kraus stage 3, according to Lisan in 2017. Our approach is that of, number one, we do generally a good biopsy, wherein we have as much as possible, we take a good look at it. Number two, imaging investigation, wherein we look into the extent, the origin as well. Planning is also important. Usually it's endoscopic, but sometimes it can be limited, so we may do external as well as the combined type. C, for complete extirpation with intent to cure. A, we make a wide opening, especially in the maxillary area, for a large monitoring space. And lastly, which we usually do after the operation, is the topical chemotherapy. So that's the BIPCAT approach for you. And here we can see that the imaging investigation, planning approach, complete extirpation, access widening, and that of the topical corticosteroids. Biopsy. Our biopsy should include an endophytic or inverted growth pattern wherein there is a thickened pseudo-stratified ciliated columnar epithelium growing downward. And so there's an underlying stroma as in this shown in this slide. And as such, this is pathognomonic of what we call the inverting papilloma. Next, we go to the imaging investigation. Usually, it would show us the extent, it would show us what sinuses are involved, and finally, what is important is the attachment of the origin of the disease or where they started from. Because once we are able to identify the origin, we're able to do something about that and remove everything. So this is an example of a CT scan, and then we see here some kind of thickening in this area, okay? And also in MRI, this is what we call the convoluted seripetiform pattern, or CCP, which we see in CT scan in 2T weighted as well as in T1 weighted. So again, as shown in CT scan, you would see some what we call the focal hyperkeratosis, okay, as well as some areas of osteitis. So always look for just for that osteitis as well as the focal hyperostosis. So hyperostosis in CT scan, as reported to us by Lee et al. In 2007, this focal hyperostosis usually would predict the origin of the tumor. It would appear that as plaque-like bony thickening in the lateral wall of the nasal cavity, or it would appear as cone-shaped bone thickening along the walls of the paranasal sinus in the bony septum, particularly in the lateral as well as in the anterior or in the medial portion or in the posterior portion. So always look for a cone-shaped bone thickening. And on USOF also cited that on CT scan, the areas of osteitis. And on CT scan, we also would predict the origin of inverting papilloma. As such, in this case, you can see this kind of area here, okay, which is cone shape. Okay. So look for that, look for osteitis, look for a focal hyperostosis, and in this case, such as this one also. And sometimes you may also go into this area, okay, so some thickening of bone. Okay, so always look for this area because that could be the origin. And concentrate once you open it up and once you've operated on, always concentrate on this area and do something about it. Okay, the key to success, look for the attachment, look for the osteitis or the focal hyperostosis, and focus on that area during the dissection. Now we look for the planning for the approach. As I told you, we're now also doing the endoscopic. The external has now been relegated to the past. We don't do any more medial maxillectomy, but if we do have some difficulty, as in some cases, we would also do opening up via the Calduolac approach, and especially that in the lateral portion. Or a combination, it could be endoscopic and the external approach. Here we can see that in meta-analysis outcome, comparing the endoscopic, external, and the combined, more or less, they are the same, okay, with the recurrence rate, as we can see here, is almost the same according to this study by the Peter Wang group. Next, we would always aim for an intent to cure. So we would do complete extirpation, not just removing the mucosa, not just subperiosteal dissection. Of course, we also do drilling of this area, particularly in the area where we think there is the area of origin. And aside from drilling, we also cauterize the area at the end. So soft tissue removal, subperiosteal dissection. Apart from that, we do a lot of dissection by drilling and then cauterization. We try to kill as much as possible the area where we think there is a possible residual. So next is access widening. So we wanted to have a good post-operative surveillance. The widest space possible, all areas should be visible, whether by zero or angled scope, and that's very important. We can do medial maxillectomy, turbinectomy, ethmoidectomy, and even for frontal sinuses, we do draft 3. So as much as possible, we do a wide opening, and as such, we can see that as much as possible, we'll be able to look into this area with this one. And lastly, we do topical chemotherapy using 4% 5FU. We did it in maxillary carcinoma. We did it in ameloblastoma. And now it's 5FU is a metabolite used in cancer for breast and basal cell carcinoma. We do the congestion and debridement, applying it twice a week for about 8 to 12 weeks. So this is our approach, the BIPCAT approach. Always look for the best solution for any problem. And every time and any time, prevent, always make sure that you've always delivered everything. So that has been our experience, and I hope you can also try to do this experience using the topical chemotherapy. Thank you very much.